Judd will be introducing our speaker. But before he introduces our speaker, I just want to welcome the people on Zoom, tell you a little bit about us. We're the Global Center for Integrated Health of Women, Adolescents, and Children, the Global WACh, which is a lot easier to say than what I just said. And then our mission really is to try and understand how to take care of all those three populations, especially thinking through the life cycle and thinking about them. I want to particularly thank today our generous donors, Carrie Rhodes Nigam, people mind waving, and her husband, Michelle Nigam, have donated an endowed lecture format for Global WACh to bring people here. And it's called the DELV in honor of their children, one of whom is here. Welcome. And also just the word DELV means how do we delve better into collaborations and how do we actually make connections work better? And so truly an honor to have our visiting speaker too, help this process with our relationships and thinking through what relationships mean with the Kenyan public health institutions. So I just finally want to say there's a reception after this, which will be just upstairs. You can follow people there. There'll be posters and opportunity to talk with one another and with the speaker. There's also a really great opportunity tomorrow at the Kenya Research Training Center talk that will be given, and there'll be opportunity to have one-on-one time there as well. And then there'll be another discussion on Thursday with the Working Group in Implementation Science, or WACh. So lots of opportunities to engage with Dr. Sultani, and I won't say anything further so that Judd, the co-director of Global WACh, can also take time just to introduce our speaker. Thanks.
Thank you, and thank you all for coming. Thank you for those of you on Zoom. It really is, I know this is maybe a cliche remark, but it really is a true honor and a pleasure to have Dr. Sultani here with us today. I've known Dr. Sultani for, I don't know how many years, but many years, and interacted with him in a number of fora where I've really always found his counsel to be incredibly wise. And I think he's been a good mentor in terms of really understanding what it takes to take evidence and what types of evidence are needed and actually turn that into policy and practice, and really helping to bridge that divide. It's been, I've worked with him in his capacity, which I'll talk about in the introduction, in neglected tropical diseases, and it's been amazing to see how much progress was able to be made under his leadership. So with that, I will introduce our speaker. Dr. Sultani Matendechero is here from Kenya. He is the director of the National Public Health Institute, which is a newly formed institute in Kenya that's really been mandated to bring together a whole variety of different organizations and groups that are working in public health and really spearhead the leadership across those. Prior to that, he was the director of the Vector-Borne and Neglected Tropical Disease Program within the Ministry of Health in Kenya. And prior to that, actually, he had studied both clinical pharmacy as well as international studies. Did masters in both of those, and before that was at the National Defense College. So has quite a lot of experience and a breadth of subjects and topics. And in talking with him, I really was excited to hear that a lot of his interest in evidence started as a clinical pharmacist, and really trying to understand how to improve clinical care in clinical pharmacy, and really has taken that now into very senior leadership within the ministry. And it's just a pleasure to have him here to talk with us. As I said, he's a good friend and a colleague, and I'm really excited for all of you to get to hear from him. Dr. Sultani.
So thank you very much, Judd, and thank you very much, everyone, for finding time to come so that we can be able to discuss a number of important issues, with regard to public health generally, and how this feeds into the global health agenda. And it's indeed big, it's something really great to be here today, because for a long time, I have had interaction with this great institution. And so it's a big honor for me to be here today and speak to you about something that I find really dear to me professionally and even just generally. So as Judd has said, over the last 1 year, I have been engaged in trying to reorganize the way in which we conduct our public health functions in Kenya. It has been a very interesting experience, And so I'll be basing a little bit on that, just to be able to speak about, how we can be able to leverage public health. Before that, I worked quite a bit in the neglected tropical diseases area. And so much as that might not be the core of my talk, from time to time, I'll keep on maybe using that as an example. But at the end, if we have time, then probably we can look at a quick example of what we are talking about. I hope that I'll be able to I'll be able to move these slides without, how do we do this? Without interfering with the presentation. So I have put together a few slides.
Oh, no.
Just to help me, to guide me through the presentation. But I'll be speaking to it. I don't like, speaking to people who are reading, but just to kind of like guide me through the presentation. So as Kate tries to put the slides out there, maybe I can just start by generally talking about public health as a starting point. I know that that's our area, so most of us are quite comfortable with what it is. But the other day we were having a meeting, and I just, somebody asked me to try and explain what I just started. Okay, thank you very much, and sorry for that. Yeah, so we had this very interesting discussion about public health, and somebody asked, so what's the difference? What is it around health, public health? And we had a lot of discussion, but the long and short of it was that, a lot of people tend to look at health within, through the lens of biomedical sciences. And, with this discussion, because we were having this meeting where, there were lots of stakeholders from different sectors, and we were looking at coming up with a country position on, efforts to come up with a new pandemic treaty, pandemic preparedness treaty, following what we have observed with COVID-19. So we had people from Foreign Affairs, we had people from the Attorney General's office, lawyers, and, that was a very good area to be able to discuss about public health. But one of the things that came up was that much as everybody looks at public health within the lens of biomedical sciences, it's generally not just a science, but it is also an art. You'll find that when you look at it, the scope is quite broad. And when you try to now summarize the scope of public health, you'll find that it ranges all the way from disease prevention, through health promotion. And we are also really striving to prolong lives, not just the number of days, but we also want to improve, the quality of life, even as we try to, prolong the number of days of our lives. But there are some very important things when you now start looking at public health. Generally, you can unpack that and find that, these summarized kind of, the scope, it represents quite, a lengthy kind of continuum that we will see a bit later in this talk. Interestingly, public health is not something that we can now talk about just, can be delivered by individuals. It is a collective effort. And so it brings about the issue of many players and the importance of being able to have an organized engagement of all these stakeholders for us to be able to get the results that we need. And at the same time, as these stakeholders are engaging, then we need to have informed, choices coming out of them. So there is a lot of information that comes into play. And at the same time, there is a lot of engagement. And these players, can be anyone, the whole of society. We have organizations, we have communities, both private and public, and we have individuals, all of them participating in making sure that we are able to implement our public health functions. So in a nutshell, what I'm saying is that, in discussing public health, you'll find that apart from the health sector, whether it is human health or animal health, you'll find there's engagement of the legal system, there's engagement of, trade, whether you're talking of, say, like COVID, and it is being driven by trade interactions, we have to bring them in. Whether you're talking of cholera, the water sector, environment sector. So we have all the sectors in government having to come on board. But over and above that, we also have to consider the non-state actors because they also play a very important role in public health. And that's why we talk about a whole of society approach. And as we kick off, I think that's very important to be able to look at it as an engagement that is going to involve each and every stakeholder in the community. Now, another thing about, looking at public health is around the fact that where we are looking at, health promotion, we are also interested in disease prevention, as we had summarized before. But at the same time, we can go further and even prepare for disease, because many times we will really struggle to prevent, but then you find that the disease occurs. So when it occurs, how prepared are we for it? So we have to be forward thinking. Do we have sufficient medical countermeasures to be able to deal with the disease or public health emergencies, public health threats, public health events? And when that happens, then we need to be able to detect early so that we can contain these events at source. At the same time, we should be able to respond effectively so that we don't have a situation spiraling out of control, so that whereas we just had a public health event, it now quickly develops into a public health emergency. And then, of course, the system, and we have seen this from the COVID experience, the system will from time to time take a beating. So we also have to factor in issues around recovery so that we can prepare ourselves for the next public health issue. Now, at this point in time, I just want us to now start looking at, within the context of global health, we talk of universal health coverage every day. And it is important for us to just maybe quickly look at what is the role of public health, global health, in achieving a universal health coverage. This is something we are grappling with a lot, across the world. In global health, we say that we not only want to improve our health for all populations, but we want to also achieve equity in health so that everyone, everywhere, is able to achieve the kind of healthcare that they need, across board, whether it is from health promotion, whether it is preventive health, whether it is curative health, whether it is, rehabilitative services. Everybody needs to be able to access this, across board. So I want to now try and funnel this towards what I have been doing over the last 1 year, trying to reorganize the public health space so that we have better delivery of the public health functions. And from what we have discussed, it is clear that public health functions, by their very nature, they are fragmented and spread across sectors. You can be able to see animal health sector is involved, human health sector. We have talked of the water sector, all sectors in the whole of government approach. But the truth is that these functions are fragmented and they are spread across all these sectors. So what happens? If we were to look at the implementation of public health functions as if they are a continuum in a straight line, then you would find that at some point in that line, there is duplication of effort, So what is being done by the animal health sector in trying to contain maybe a rabies, an outbreak of rabies in dogs, the animal health sector is grappling with it. At the same time, the human health sector, there are, activities going on to try and respond. A lot of the time, you'll find that these activities, these efforts are duplicating. There's an overlap. There's a cholera outbreak. The human health sector is trying to contain this disease. The water sector is doing the same. So you'll find there's a bit of overlap in what is happening. The private sector is also coming in. So if it was a straight line, a continuous line, you'll find there are areas of duplication. And with this duplication, you'll find that we are wasting resources because, these are things that would have been done by just one, maybe agency, one department, or one ministry, but it's being duplicated. Resources are being wasted. The resources for public health are finite. They are not infinite. So if we are wasting these resources by duplicating effort, it means that there are some functions which are not going to be funded. And so that further complicates our theoretical line, so that you find, whereas we are duplicating effort at some points, there are other points where we are not financing important functions. And so there's a gap. We start having gaps within our continuum. But more importantly, where we have multiple stakeholders doing the same thing, there will always be lack of leadership and lack of accountability. So what is the outcome of all these duplication of effort, lack of leadership, lack of accountability, wastage of resources? The outcome is that we are very slow in responding to our public health threats, public health events, and we are not able to respond to our public health emergencies on time and contain them before they cause lots of damage. But at the same time, we have our existing public health programs, which are supposed to serve the population. Now, because of what we have said, the duplication of effort and all that, the existing public health programs are not efficient. And so you will find that we have reduced impact of these existing programs. And that's a big problem. So at the end of the day, we are saying that we need to have a strategy, and most likely at national level, so that we have capacity to lead and coordinate public health functions across sectors. So that if we are having a problem, then we are able to make sure that all those players are reading from the same page, and we are able to move with speed and to respond and contain the public health threats as they occur. I'm trying to move with speed because I want us to be able to finish this and have a little bit of an example. And this is where I bring in this national level institution that I just alluded to in the last slide. And this is what we call the National Public Health Institute, what we have been really struggling to establish in Kenya. In the US, we have the US CDC, which plays the role of the National Public Health Institute. And we have been able to see the contribution that this institution has made when it comes to public health issues in the US. In other parts of the country, we have similar institutions which are playing that role. So lots of people have been able to put together several functions which can be played by these institutions. In Kenya, we have picked out about 3. You can group these functions into about 10, but we have picked out and prioritized 3, which I have just isolated on the first slide. So for our National Public Health Institute, we are looking at issues around surveillance, the surveillance systems. We are looking at public health laboratory systems, so that if we are able to pick out something that looks like a public health threat, we are able to quickly confirm if it is a public health threat so that we can respond. So it moves the whole way, from public health systems, laboratory systems, surveillance systems, to disease preparedness and response. The other thing that we are paying attention to at this stage is public health workforce development. And not just because of COVID. Actually, there are a lot of circumstances that have made us aware of the big gap that is existing within our public health workforce, at various levels, at national level, at regional level. So we really have to look at being able to put that in place. And then the third part, which is of even greater interest to me today, is the issue of research in public health. And unfortunately, we have overlooked, especially in the global south, we tend to overlook the importance of research, the importance of evidence, the importance of scientific data, and the use of this evidence in informing policy, the use of this evidence in making decisions, evidence-based decisions, the use of this data, scientific data, in planning so that we become much more efficient. So there is a catastrophic breakdown between research and implementation. And we have seen the kind of negative effect that this has had on achievement of our public health goals. So research in public health, we have actually put it out as one of the key initial functions, core functions that we want to be able to drive with our National Public Health Institute. I might not spend time on the other functions, but there are a whole range of what we talked about initially, from disease prevention all the way to health promotion, very important advocacy, communication, social mobilization, the whole continuum around being able to inspire behavior change, things like health education, extremely important because sometimes when we go out to the field, we experience very interesting challenges. There's this time when I went to a village in the coastal part of Kenya, called, there's a county there called Tana River, and there's a village called Kipini, where we were conducting some, community engagement on neglected tropical diseases. And as we were discussing, we were planning to implement mass drug administration for lymphatic filariasis, what we call elephantiasis. And as we were having a community engagement, one of the ladies ran up to us and they said, Daktari, that's a doctor in Swahili. Daktari, it's good that you people have come. I have a big problem here. My son, there was a young boy about 7 years old. My son is already 7 years old and he has not started having his period. So we were really confused because, okay, your son, 7 years old, has not started having his period. So it was a bit confusing. But as we continued engaging, we realized that the burden of schistosomiasis, bilharzia, in that community was so high that by the age of 5, all the children have started passing blood in urine. So this young boy is already 7 years old. He has not started passing blood in urine. So what is this? There is a delayed milestone here. How can you help so that this boy can, be like all the others? So you find that the issue of advocacy, communication, educating the community so that they understand their public health problems. And now you are confronted with a situation where this community does not even understand that this is a problem. This is a public health problem. Instead, they think that it is a normal way of life. So where do you begin from in terms of addressing such a public health problem? Yeah, so there are quite a number of functions that can be played by these institutes, in terms of engaging the community, providing health education, population health and health-related indicators, and all that, including policies, quite a number of functions. Because of time, we might not be able to go through all of them. Now, in trying to organize our public health functions into a national level institution, this is something that started almost 10 years ago. And when I was given this responsibility, I was told that, you know, we have been trying to establish the National Public Health Institute. And this has been very challenging. But we have seen what you have been able to achieve with the Neglected Tropical Diseases Program. And we think that if we can apply some of what you have done, maybe we can be able to achieve this objective of having this institution. So we are hoping that if we can provide support, probably in another 3 years or so, we can have such an institution. But then I looked at it and said, 3 years is a long time. Why should we, you know, spend a whole 3 years? And I took the first 2 months because where I come from in Western Kenya, there is a saying that if you want to fell a tree and you are given 6 hours, you can decide to use the first 2 hours to sharpen the axe. And then you use, actually we usually say the first 4 hours just to sharpen the axe. And then you fell the tree in another 1 hour and you rest for another 1 hour as you wait for the evaluator to come and see what you've done. Or you can just start trying to fell the tree with your blunt axe. And after 6 hours, you have not yet, you know, the tree is still there because your axe is blunt. So I took a little bit of time just to look at the, you know, the landscape and understand what is it that is stopping us from establishing this very important institution. And it was very interesting what I discovered, you know, a lot of issues around, you know, differences in opinion, you know, people wondering what is the scope of this institution, what happens to the already existing departments and the agencies and institutions, will our work become redundant? So there was a lot of issues that had to be navigated very carefully. But once we were able to understand end to end the issues, the fears, you know, at one point even I realized that the name of the institution was a problem. There are some people who said we should call it the Kenya CDC so that it looks like the America CDC. Others are saying, no, we want something that is different. We just call it the National Public Health Institute. So there were a lot of interesting discussions around what is the scope, you know, which were delaying this. So we realized that there was also a very important political angle that had to be navigated. And so strategy had to come in so that we look at the models. Are we going to have an institution that is going to have all the functions under one roof? Or are we going to have an institution that is just going to play a coordination function, but then the implementation remains in the various sectors, in the various ministries, departments? So there was quite a bit of that looking at it. Then we also said our focus will be to identify the existing gaps so that nobody feels threatened. We identify and say, look, as we are going on doing this, we are not able to identify this important area of public health. Today, as we are not, you know, addressing this important area. So this institution will come to look at where the gaps are so that we can be able to fill them up. And then, of course, we talked of overlaps. And one of the main things at the beginning was, how do we address the existing overlaps so that we bring in efficiency? And then now, as we continue seeing the importance of this coordination, you know, the good leadership that is being provided, we can progressively move towards an all-inclusive institution. I have really moved fast because I wanted to just use a few minutes, you know, so that at the end of the day, we can also have a few minutes just to have some interactions, maybe a Q&A. But I wanted to also just give an example of what I have been talking about. I have a passion for neglected tropical diseases. And many times I cannot let an opportunity like this pass without talking about them. I know that even when we were planning this, much as Jad and his team kept on telling me, no, let's keep it a bit broad. I said, I have to squeeze in something on, I have to squeeze in something because these diseases are neglected and they are devastating communities out there. Much as we might not be seeing what is happening, these diseases are destroying livelihoods in ways that you cannot imagine. When you go out there and you see what they are doing, then you start realizing that we really have to take, steps to be able to address these relationships. These diseases. And when you look at the kind of audience that we have here, this is the future of global health. This is the direction that we are taking. And so it becomes important for us to start having an idea of what these diseases are and what they are doing. We don't have much time, but I will just say that these are a group of 20 diseases identified by the World Health Organization, and they mainly affect the poor populations and people who do not have ability to access safe water, people who do not have ability to access basic sanitation. Generally, people who are just living like wild animals there in the community, somewhere away from the rest of the world. And one of the things I keep on saying is that neglected tropical diseases, that is entities, start where the road ends. When you go now to areas which are inaccessible, that's when now you see the real devastation of neglected tropical diseases. It is very unlikely that a snake will just walk into this room and bite one of us. But as we speak, there are young girls somewhere deep in the villages who have gone to look for firewood. And as they are doing that, they will be bitten by a snake. And they'll not be able to afford the antivenom, they will die. There are young boys who are taking care of cattle, herding cattle. And while they are out there, they'll be bitten by a snake. There are kids who are swimming in the lake and they are busy getting infected by bilharzia. And, nobody is paying attention because we are not able to, that is a population that we are not able to get any return, even if we invest in these diseases. So one of the things that WHO is doing is that they are encouraging a system where we can eliminate these diseases. Because interestingly, it's very easy to eliminate them and very cheap, but very little is being done towards that. And where we are not able to eliminate, then we settle for sustainable control. So that even though the disease is prevalent in the community, but we want to keep it at a level where it is controlled. So we can integrate at various levels. We can integrate several interventions so that where we go out and give treatment to the whole community, what we call mass drug administration for diseases like intestinal worms and bilharzia, we can also be able to provide safe water. We can be able to try and see how we can work together with the environmental health department so that we can provide basic sanitation. So we integrate interventions. And for that, we have come up with a strategy that we call breaking transmission strategy, which looks at being able to leverage several interventions to be able to achieve elimination of neglected tropical diseases. Then we can integrate interventions across diseases so that we can have, if we have more than one neglected tropical diseases in a community, we go in and we intervene for all of them at the same time. So we integrate interventions. We can also look at existing public health programs and the public health system so that we can now integrate the elimination effort within, say, malaria programs, HIV programs, polio, vaccination efforts, and the general public health system. How do we leverage it better so that we can be able to address neglected tropical diseases? And then there is the issue of funding, which if we had time, we would also be able to look at the effect of over-reliance on external funding to be able to achieve elimination and sustainable control of neglected tropical diseases. That is one of the biggest bottlenecks that the areas that are faced with the big burdens of entities are having. Because if we are not going to look at domestic sources of funding, then we will never achieve elimination of entities. And the question here, because I know we are researchers, and yesterday I was given a little bit of a sneak peek into the kind of research that is going on here. I was, blown by the kind of thinking that's going on. We are not just looking at biomedical research. We are looking at, systems, approaches, kinds of new ways of doing things, innovation. And we also need to look at issues like how can we stimulate a mobilization of resources domestically so that countries can take ownership. This is our problem. We don't expect people to come in from external places to come and be able to help us to achieve our objectives. So for the next 5 minutes, I just want to give an example of, this is just my own way of looking at it. 2 neglected tropical diseases, that is intestinal worms, which we also call soil-transmitted helminths. I've captured it as STH here. And then which we also call schistosomiasis. I've captured it as SCH. What we usually do is that you'll find where there's schistosomiasis, most likely there's also the soil-transmitted helminthiasis. So what we usually do is, in an integrated way, we go and target the community and deliver treatment. To the masses, we give treatment to everybody in the community. For the longest time, we have had a strategy which targets school children with deworming. And when I was the program manager for entities, I always used to ask, what is the rationale behind this strategy? Where we are providing medicines to school children only. And then at the end of the day, they go back home to adults and younger children who have not been treated. So what are we trying to achieve here? I had never really understood, and I really tried to take time to understand. There were lots of explanations about how that strategy works. But to me, it never made sense. And we worked together with the National Research Institute, KEMRI. We went out there, and before delivering treatment, we would pick samples and check the prevalence of disease. Then we deliver the MDA. And we saw something really spectacular. We saw a situation where immediately after the mass treatment, among the school children, if you go back 3 weeks later, you'll find that the disease has almost been wiped out of the children. And then the next year, before we deliver the treatment, we take samples again from the same children. And the first time we found that it had bounced back to about 3/4 of the burden. And as we continued, we realized that if we are going to rely on just treating the children alone, eventually we will have a situation where we will have bounce back, and we will continue delivering this intervention for the rest of our lives. Investing money in it, and coming back, and we never achieve any useful long-term benefit. So we said, if we are to increase coverage so that we target the older people, the adults and the children, so that we now have everybody getting mass drug administration, I call it MDA, then we would achieve a situation where the bounce back would continuously taper down because of the reinfection. The issue of reinfection is not happening, it is being addressed. And we realized that it is possible that after 5 years, we will probably have a situation where this disease will still be there, yes, but it will have been reduced to less than 2% in most of the populations. Now, the problem became, immediately you stop mass treatment, annual mass treatment, then you run the risk of it going back up. So we asked, okay, so what do we do? Let us couple the mass drug administration with the provision of safe water and basic sanitation. water, sanitation, and hygiene. And we realized that the coverage of water, if we take it to be arbitrarily at around 40%, of course, it's less in very many communities. If we can push it up, after some time, you'll find that the effect of the safe water and sanitation actually speeds up and shortens the time that we take to get to a prevalence that renders the diseases to be no longer of public health concern. The same thing happens when we say, let us couple mass treatment with behavior change communication. So that these young children, as they go to swim in the lake or in the river, they don't urinate in the river, in the lake, because that is how they are transmitting this bilharzia, just behavior change. And we see if we can be able to reduce the time that we take to get to a place where these diseases are no longer a public health concern. But what we actually realized, because we were taking data and just looking at the anecdotal information and trying to piece things together, we said, if we have a situation where we increase the coverage, cover the whole population, then we also improve on the behavior change communication, introduce water, sanitation, and hygiene. How is it going to work out? And we discovered that it will even take much shorter for us to be able to reach a period where we don't need to give a mass treatment. But it becomes more exciting because if we can keep the water, the WACh interventions, and the behavior change up there, then we can actually stop the annual rounds of treatment without being worried that they will bounce back. So that high level of availability of water, sanitation, hygiene, behavior change becomes your sustainability bet for these diseases. And it starts giving us a real possibility that actually, as we continue, we can achieve this objective of elimination and sustainable control. I have really tried to rush through this presentation because I wanted to maybe have about 10 minutes where we can have maybe one or two concerns raised. But what I would just say is that as a community where I think this is a leading institution when we look at issues around research in global health, training and learning about global health, let us find time. And, even as we implement some of these cutting-edge public health approaches, let us also find time and pay quite a bit of attention to these diseases that are affecting millions and millions of poor people across the world, affecting economies. Because, when they are sick, economies cannot grow. So that we can maybe contribute in a way towards elimination and sustainable control. So I will stop at that, so that if there are any, I know that we are really pressed for time. Initially, we had a few challenges with technology, but that would be what I want to share with you today. And at this point, probably entertain one or two clarifications, questions, and maybe points of discussion. Thank you very much.